Hey everyone, welcome to Professor Long's Lectures in Anatomy and Physiology. You guys know coronavirus shutdown, blah, blah, blah. These videos are intended for use by students who are enrolled in my Human Anatomy and Physiology class. If you're not in my class, maybe you'll learn something from watching this. Again, these videos are all being done in one take with my cell phone, and they take a lot of time, effort, and energy to get them right, get them into YouTube, get them uploaded to my page, so I'm doing the best I can. Some videos, the quality's on, and some, I know some areas I trail off or miss something. Just bear with me, I'm doing the best I can, and I'm going to keep trying to update videos as I see fit. Now, if you're following along, I believe this is our 5th video in the endocrine series. Essentially, what we've covered is all the pages in the end and the note set up to page 27, although we skipped page 26. In the last video, we were talking about prolactin, growth hormone, melanocyte-stimulating hormone, and we did the thyroid hormone. We're doing complex endocrine pathways, and there's 7 hormones that we're going to look at in this pathway. We have already done adrenaline, the direct neural stimulation of the adrenal medulla under prolonged stress. That's one hormone. We did oxytocin and ADH of the neuroendocrine pathway or the posterior pituitary. So that's up to 3 total now. And then we've done thyroid hormone, prolactin, growth hormone, and melanocyte stimulating hormone. So I believe we're like 6 or 7 hormones in. We only have like 10 or 11 or 12 to go. Now I did skip page 25 in my note set, page 26 in my note set last time. There was a reason for that. Also on page 27, I forgot to mention last time, I want y'all to look up the definitions of pituitary dwarfism, giantism or gigantism, and acromegaly. They're related to growth hormone and disorders with growth hormone. So look those up. Know those definitions, know what's going on. Now, I'm going to start on page 26 of the note set, and we're going to do some hormones on page 26, follicle stimulating hormone and luteinizing hormone. And then I believe we only have one more hormone left to do the complex endocrine pathways. Sorry, that beep you hear is me setting my timer, so I know to end the videos before it kicks to a second video. So now, follicle stimulating hormone and luteinizing hormone are related to the sex hormones, testosterone, estrogen, and progesterone for both males and females. So they're a little bit more complex, and the reason I wanted us to do them separately is I want to have enough time to cover them adequately. So we're going to cover the hormones on page 26, FSH and LH, as they relate to both the male and the female physiology. And I know there's a whole lot of discussion about, how many genders are there, this, that, and the other. And this becomes a complex issue in healthcare because there are people that are male that consider themselves female and identify that way. And there's all this, how do you identify? What gender do you identify with? Regardless of that, and some people, get really upset. There's even a lawsuit of a man who wanted his doctors to refer to him as a female on all their paperwork, and they could not. Or at least one physician refused to and lost a job. And this becomes a complex issue because sociologically, we should be sensitive to things. But biologically, chemically, physiologically, if you have testes, you're not producing estrogen and progesterone. The likelihood you're susceptible to breast and uterine and ovarian cancer is pretty low. If you're a male, then you have the likelihood of having prostate cancers. And some cancers and some disorders and diseases are more prevalent or common or occur at a higher percentage in males than females and vice versa. So, our gender affects our physiology. And I don't want to get into the arguments or discussions with y'all, but I just want you to know that when you become a healthcare professional, knowing the gender of birth of your patient has a lot to do with a lot of their physiology, their susceptibility to certain diseases, heart disease, blood pressure, all sorts of other things that are going on. So anyway, these hormones are going to relate to the genders, and so we're going to do each hormone twice, once for the male, once for the female. So we're going to start with follicle stimulating hormone. Now these are complex endocrine pathways, so just to remind you, up in the brain, we have the thalamus, then we have the hypothalamus, and then we're going to be looking at the anterior pituitary. We're going to have another endocrine organ in the pathway, and then we're going to have a target organ, okay? And as you know, there's going to be blood vessels that link all of these that the hormones will pass through. If you've been watching my video series, you know what I'm talking about, okay? So now, I'm going to draw all of this in a much larger, more easy to follow form. So And we're going to list everything that's going to happen here also. So now, here's our hypothalamus. Because these are complex endocrine pathways, they involve the hypothalamus. They're going to involve the anterior pituitary. I always draw anterior on the left and posterior pituitary. Sorry, I was thinking of pituitary and posterior at the same time. Anterior and posterior. This is just the way that I do it. And then what we're going to have is we're going to have some target cells somewhere in the body. Again, I'm a diagram guy. Occasionally, we're going to have an endocrine organ. And in most of these, we're going to have an endocrine organ anyway. And really what's going to happen is the endocrine organ is going to be the target for one of the hormones, and then there will be an additional target or additional organ that we can target, and we're going to get the response. Okay, it's a little bit different than the other systems that we were writing out. So I can draw some cells with receptors here, and I can draw the blood vessels connecting them all, and we can plug in all of these hormones. As you know, we would detect a stimulus up here, and then we'll release a hormone. It'll travel through the bloodstream, release a hormone, release a hormone. Complex endocrine pathways often involve many different hormones. So we have what's called the hypothalamo-hypophyseal portal system. Those are the specialized blood vessels that connect the hypothalamus to the anterior pituitary. I haven't covered that before, but anytime we go through the anterior pituitary, there's a series of blood vessels called the hypothalamo or hypophyseal. It's all one word. So if you want to sound really, really smart to your friends, say, well, you know, we're studying the hypothalamo-hypophyseal portal system. Don't tell them, oh, we're doing hormones in the anterior pituitary. So anyway, it's called the hypothalamo-hypophyseal portal system. This means hypothalamus, this means pituitary, and portal comes from the word puerta, which means a doorway. That's just the specialized blood vessels that connect the hypothalamus to the anterior pituitary. All complex endocrine pathways, except for melanocyte-stimulating hormone, which is questionably complex, but nonetheless, utilize the hypothalamo-hypophyseal portal system. Those blood vessels connecting the hypothalamus to the anterior pituitary. I thought I'd throw that in there. I was going to cover it at one point, but I think I forgot to. And then we're going to have hormones that go from there to an endocrine organ, and from that endocrine organ to another target. So now I'm going to follow both the male and the female, and without trying to offend people, I guess I'll use some neutral colors so we don't offend anybody. Okay? I'm going to use purple and green. When we do the female system, we'll do green. When I do the male system, I'll do purple. And what we're going to have for these systems is we're going to have what is the stimulus, and sometimes that stimulus will be the same for each. We're going to have the hypothalamus releases or secretes, and then we'll have the anterior pituitary. I'm going to abbreviate here, but it should be written in your note set, releases. And then we're going to have, really what we have in the note set, the way that I have it written is I have a target, right, which is really going to be this endocrine organ. And then we're going to have a response. And in that response, we're actually going to target another organ. So this drawing doesn't exactly match the list that I wrote in the note set, okay? Because when we target this organ, we're trying to get a response out of it, and that response is going to subsequently affect another endocrine organ or another organ in the body. You'll see what I mean. So let's start with the first one. The first hormone we're going to do in this pathway is going to be FSH. Okay, let me use blue since I'm using purple for the males. This is the international symbol for female, international symbol for male. FSH stands for follicle stimulating hormone. Of course, that's my abbreviation for hormone. I hope you know it by now. FSH, follicle stimulating hormone. This hormone was first discovered in females. Turns out that was also later discovered in males, but it has the same name since it's the same compound. And the name tells you it's going to stimulate the follicle. So before I go into the hormone, I want to give you a little bit of background on this. When you look at the ovary, if you've watched the video on the anatomy of the ovary slide, one of the things that I like to point out is this. The female ovary has these small round structures, thousands of them, and within each one of those structures is a small cell called an oocyte. Each one of these structures is called a follicle. Depending on what stage, they can be the primary follicle or the primordial follicle, but these are, I'm going to call them primary follicles. The one with the little aught or prime there means primary or first degree, first level. The primary follicle is going to have a cell inside of it called the oocyte. Females are born with way more of these follicles than you'll ever need. When we reach reproductive age, females, as we secrete a hormone, these follicles will start to mature or get bigger. As they get bigger, and these are not drawn to scale, they don't really get this big, but there's a cell in here called the oocyte. During that development, lining the follicle will be a little ring of cells all the way around, and some of those cells will also surround the oocyte within the follicle. And the oocyte and these cells are suspended in the middle of the follicle in a fluid called follicular liquor. I'm not really worried about that. But at this stage of development, we call that a secondary follicle, okay? Or the second degree, secondary, primary, secondary. Now, eventually, this follicle is going to even enlarge even more. And for some reason, every month, only a few follicles will start to progress through this process as females go through their monthly menstrual cycle. The oocyte also enlarges. But one of the things that happens is some of the cells that are hugging the inside of the follicle and the cells that are wrapped around the follicle will actually grow together, and the follicle and these cells attach to the inside of this entire follicle. There's still fluid in here, but the cell's not suspended in the middle. At this stage, we call this a tertiary. Tertiary means third level or third degree. It's called a tertiary follicle. It's also called a Graafian follicle after Dr. Graaf, who first discovered or described it. So the female follicles, every month, a handful of the thousands will start to mature into secondary follicles. And usually only one will make it, or a few will make it to the tertiary follicle stage. And at this stage, the egg is so developed, it's ready to be released or ovulated. So this process is referred to as follicle maturation. What stimulates the follicle to develop from primary to secondary to tertiary is this hormone. It stimulates follicle maturation. That's the process. So now that we understand that, I can write all of this out. I'm going to erase my picture here so that you guys can know what I'm talking about when I use this terminology. So now, in a female and in a male, the stimulus for follicle stimulating hormone release is going to be several things, a couple of things. One will be normal sexual development. Okay? Your body is developing like it normally should, whether you're male or female. And you're going to start releasing certain amounts of FSH, and they're going to go up and down. Because when it's low, we start releasing more. When it gets too high, we stop releasing it, so the concentrations will drop. When they get too low, it turns itself back on. So just like your air conditioning unit monitoring itself, turning itself off and on. So one of the other stimuli is a low concentration of FSH in our blood for both males and females. Now the hypothalamus is going to release a hormone called gonadotropic releasing hormone. It stands for gonadotropic releasing hormone. Capital G, little n, capital R, capital H. Gonadotropic releasing hormone. Now originally this hormone was called FSHRH, but it turns out they had to change the name, and you'll know why in a minute. And this happens in both males and females. Males will also secrete gonadotropic releasing hormone. So low concentration of FSH or normal sexual development, and then here we're going to release gonadotropic releasing hormone. That's going to go and bind to an endocrine organ. Well, I have that listed as the target. Actually, gonadotropic releasing hormone from here is going to cause FSH to be released at the anterior pituitary. The hypothalamus releases gonadotropic releasing hormone. The anterior pituitary will release FSH in both males and females, follicle stimulating hormone. Now in females, the target is going to be the ovarian follicle. That would be here, okay? The ovarian follicle is at this level. The response is going to be what we call follicle maturation. The follicle is going to mature within the ovary. Those little ovarian follicles that I just drew and erased here will mature from primary to secondary to tertiary follicle. So we say follicle maturation. We go from primary to secondary to tertiary follicle, preparing for what's going to be ovulation, release of the egg so that it's ready for fertilization. Now in females, a secondary thing happens. So I'm going to change the color just so that you can follow along here. In response to this, in females, the maturing follicle it's supposed to be an M. Sorry, let me erase that properly. The maturing follicle releases or secretes estrogen. So now I'm going to get estrogen going from the follicle to another organ. And estrogen will target the endometrium. The endometrium is the lining of the uterus. Now, once the follicle is released, if it gets fertilized, until the developing fetus develops a digestive tract and blood vessels and can connect to mom and get nutrients from mom, the uterus itself, way down here, the uterus is going to have several layers. The muscle layer of the uterus is the myometrium that will cause contractions for birth and orgasm. But the lining of the uterus is called the endometrium, and it has blood in it. And so what's going to happen is, as the follicle is maturing, it wants to cause the lining of the uterus to engorge with or thicken with blood. That blood is going to be rich with nutrients and oxygen, so that if the egg is fertilized, when it starts to implant, it can absorb all the nutrients and amino acids and oxygen and everything that it needs, glucose, to survive and develop in all its cell divisions until the baby develops, or the fetus develops a heart and blood vessels, connects through the umbilical to mom's blood vessels, and then gets the same nutrition that mom eats. But for a while, the only nutrition comes from the endometrium. So estrogen targets the endometrium, and it increases the thickness of the lining. Or we can say that it engorges with blood. Okay? So in a female, if FSH levels get too low, or at some point you reach puberty, then the hypothalamus releases gonadotropic releasing hormone. Gonadotropic releasing hormone targets the anterior pituitary and stimulates it to release FSH. FSH will target the ovarian follicle and cause follicle maturation. The follicle will develop from primary to secondary to tertiary. As it matures, the cells in the follicle are going to continue to release estrogen, and estrogen will target the uterus and cause the endometrium of the uterus, the internal lining, to thicken with oxygen and nutrient-rich blood. That's what happens in the female. In a male, gonadotropic releasing hormone from the hypothalamus targets the anterior pituitary. The anterior pituitary releases FSH, but in the male, it does not have an extra step for FSH. So in males, if I continue along this same line, the target in males is going to be what we call the seminiferous tubules. Now again, I'm used to doing all this stuff on really large boards where I have lots of room to write, and doing the endocrine system on such a small board is kind of tough. Now, if you recall, when we studied the testes in lab, one of the things, I'm going to erase a little bit of this. I hope you have this information down. I'm going to erase this because I need room to write and show you something. When it comes to the testes The testes are oval masses just like the ovary. They actually develop from the same tissue. There's a tube that enters the testes and then coils up and then will exit out the penis. Okay, this is called the epididymis. This is called the vas deferens or ductus deferens, and that's where sperm and the ejaculate would be released. But the sperm are produced inside the testes. As this tube enters the testes, it breaks up into hundreds of smaller tubes that coil up like crazy in here. Okay, and as these tubes coil up in here, if we were to slice the testes open in a particular spot, I would be looking at these tubes on end, and hundreds of these tubes. These are called seminiferous tubules. And inside the seminiferous tubules is where the spermatozoa are being produced. So FSH is going to target these seminiferous tubules, and the response is going to be, it will initiate or start off sperm production. Sperm are the cells that will fertilize the egg or the oocyte. So in females, it causes the oocyte to develop within the follicle maturation. In males, it causes sperm to start developing. Now, FSH will cause a certain amount of sperm production. Another hormone is going to raise it to a level that increases the number, but FSH will at least kick off low levels of sperm production. There's no extra step in males, okay? So in females, gonadotropic releasing hormone will be released at the hypothalamus, target the anterior pituitary, cause FSH released. FSH targets the ovarian follicle and causes follicle maturation. That maturing follicle releases estrogen, and estrogen will target the uterus and cause it to engorge with blood to prepare for pregnancy, implantation of the fertilized egg if it's fertilized. In males, gonadotropic releasing hormone from the hypothalamus causes FSH release at the anterior pituitary. That targets the seminiferous tubules of the testes and initiates sperm production, and it ends there. Now, I'm going to do luteinizing hormone, and I'm going to erase some of this, okay? I'm going to do males first, since I already have this set up here. And we're going to do the next hormone, which is called LH. And I'm going to talk a little bit more about LH and hopefully finish it in the amount of time that we have. So we're going to talk about LH, and the L stands for luteinizing hormone. Okay, luteinizing hormone. Now, the stimulus for the secretion of LH is normal sexual development or low concentrations of LH. Also, in males, it could be low levels of testosterone or low levels of progesterone in females, but we'll talk about that maybe in a little more detail. Now, turns out the same hormone that causes it to be released is the hormone that causes FSH to be released. When I was a student, they called them FSH-RH and LH-RH. Turns out FSH-RH and LH-RH are the same compound, so now they just call it gonadotropic releasing hormone. The gonads in the male are testes, the gonads in the females would be the ovary. So, I'm going to follow the male pathway first, since I already have this picture up. Now, in males, gonadotropic releasing hormone will target the anterior pituitary. The anterior pituitary will release luteinizing hormone. Luteinizing hormone is going to target what we call the interstitial cells of the testes. So if you remember in lab, we had the image of the slide, we had all the seminiferous tubules with the spermatozoa in front of them. In between these tubules, there's cells out here, in between all of that, called interstitial cells. It turns out that LH targets those interstitial cells. In response, now we're going to have an extra step in males. So, gonadotropic releasing hormone targets the anterior pituitary, it releases LH. LH is going to target the the interstitial cells of the testes, and it's going to stimulate them to release testosterone. So these cells are going to release testosterone. That's the response. It targets the interstitial cells. The response will be increased testosterone secretion. Okay? Now, testosterone is going to target the brain, skeletal muscle. I'm going to erase this now. It's going to target connective tissue as well as a few other things. It will target the seminiferous tubules. So it's got several targets. So as we release testosterone, I'm just going to put a T here for testosterone. Testosterone, excuse me, I dropped a marker, is actually going to target our brain. One of the things it does in males is it causes us to have a little bit more aggressive behavior, more aggressive attitude, a more willingness to compete, all the testosterone posturing, all the stuff that, sexual aggression. Usually it's males that want to initiate the encounter, to initiate sex. So we become very territorial and, hey, dude, stay away from my territory. I'm the alpha male. These are my girls. This is my food, my blah, blah, blah. All that machismo stuff. That's what's going to do in the brain. In skeletal muscle and connective tissue, that will cause increased growth, increased protein synthesis, and increased mitosis. So we get bigger muscles in general, larger and thicker and stronger bones in general in males than females. And more connective tissue. Our ligaments and tendons will become thicker and stronger. But in the seminiferous tubules, one of the things it will do, it will increase sperm production. So it's FSH that starts sperm production. LH will increase sperm production. So testosterone will actually go back to those same seminiferous tubules that FSH targeted and massively increase the number of sperm being produced. If males are low in LH and testosterone, they have a low sperm count, usually infertile. All right? So now we know LH in males. It's got an extra step. It's still gonadotropic releasing hormone at the hypothalamus, targets the anterior pituitary. The anterior pituitary releases LH. LH targets the interstitial cells in the testes, the cells in between the seminiferous tubules, and it causes them to release testosterone. Testosterone will target the brain and cause increased aggressive and male-type behaviors, increased risk-taking and all of that. It will target skeletal muscle and connective tissue and increase growth and development, so we get bulked up. And it will target the seminiferous tubules to rapidly increase sperm production. We also get the secondary sex characteristics like the facial hair and loss of hair and body hair pattern and all of that. Okay. So now I'm going to erase all of this. I hope you got that. If not, you can read it in the book and watch other videos. And I guess I could have left that up, but we need to talk about females. In females, gonadotropic releasing hormone, due to low LH, will be secreted. Gonadotropic releasing hormone targets the anterior pituitary and causes the secretion of LH. Luteinizing hormone from the anterior pituitary is going to target the ovarian follicle. Oops. But this time the response is going to be two things. First, it's going to result in ovulation. So in the ovary, that follicle will fuse with the edge of the ovary and it will release the oocyte. And that release is called ovulation. So if you think about it, there's still these cells that line the follicle, but there's a little crown of cells around the oocyte. So if you think about it, if you wanted to, as the follicle matures, FSH is causing follicle maturation, and that's going to do estrogen. Okay? LH is going to cause ovulation, the rupturing of the follicle and the release of the egg. Now, in response to that, what remains behind in the follicle is a structure that tends to turn a yellow color. This follicle will seal up and stick around for a while. I don't have a yellow marker, plus it wouldn't show up, but they call that structure the corpus luteum. Corpus luteum means yellow body, and the corpus luteum, and I know you probably can't read that, so I'm going to change the color of what I wrote. It's called the corpus luteum. The corpus luteum is the remains of the follicle. As it seals up and retracts, the remains of the follicle, called the corpus luteum, are going to release a hormone called progesterone. So not only do I get this at the ovary, but I get an extra step. Now I'm going to have the ovarian follicle ovulate, but the remains of the follicle again called the corpus luteum, hence the term luteinizing hormone, will release or secrete progesterone. Progesterone in a female will target the endometrium. And what it will do is it will prevent menstruation. Menstruation would be the breaking off and the loss of that blood lining. Now, the reason you don't want to lose the blood is this. So I know I got a lot going on this board. These two hormones are pretty involved initially. Now, if you break it down and just do it quickly, so let me show you this. Let me erase all this. Okay? You know it's getting messy, but it's hard to do on these small boards. So the uterus is sitting here like this. It's a pear-shaped organ, and connected to the uterus are two tubes called fallopian tubes, and then the ovaries are here. Okay? When the ovaries release the egg, if the egg gets fertilized by a sperm cell, then the egg starts dividing through a number of cell divisions into a little ball of cells. By the time it gets to the uterus, hopefully, the lining of the blood is nice and thick and rich with oxygen and nutrients, so that this developing embryo can start to attach and absorb all the nutrients that it needs. Now, if that's occurring, I don't want the female to menstruate, because then we would lose the egg with it. So progesterone will target the endometrium, the blood lining, and prevent it from breaking off, so that implantation and pregnancy can occur. And all that nutrition will support the developing embryo until it grows an umbilical cord, connects to mom's blood vessels, and then gets its nutrition from mom. So now we have FSH and LH. They are very closely related, and they are both abundant in males and females. So in females, low LH concentrations and actually low progesterone concentrations will target the release of gonadotropic releasing hormone at the hypothalamus. That targets the anterior pituitary and causes the secretion of LH. LH will target the ovarian